data is generated at the place of transaction, but it can be transmitted when and as and when the service is available. So it does not require real-time online time. So in this scheme, the smart cards were used, and smart cards were issued to all the families, and you can see the statistics about more than 30. This data is a little bit old, and the recent figure is around 40 million smart cards have been issued in the 40 million families have been enrolled in the scheme in the rural areas, and the people, when you multiply with the number of family size, then it is around 130 million people. So, and that is the people who are enrolled, and the people who have got the service delivered for their own health services are around more than 6 million now. More than 6 million now. And there are hospitals in panel. What happens? Let me tell you the scheme. First of all, the people are enrolled. The beneficiaries are enrolled, and for enrollment, there is already a database available for the below poverty line. So that is taken as a reference. But believe me, that BPL list, many people talk about the BPL list. In a digitized form, it's a horrible task to refine that list, to filter that list, and make it usable for the purpose. There was one very big challenge. I will give you an example. BPL list tells about the head of family name, and then the name of all other family members, and if their age was nowhere given. The relationship, for example, in all these, there were 5-6 names, and against everywhere, beta, beti. Maybe he is a son, he is a wife, or he is a daughter. So these kind of problems. Age, nowhere was given. So that refinement of data took a lot of time, but it required a very big effort to be made, which was done, and the data was refined, and the enrollment was done, and the cards were issued. Once the cards were issued to the family members, to the families, they became entitled to get the service delivered. And the delivery of service made with the help of the health insurance companies. Hence, health insurance companies were outsourced so that government can pay premium for those families, and families can get the health service delivered through all the independent hospitals which the insurance companies have. So that way, it brought in a revolution of providing a much better health services to the citizen in the rural areas. There is a true competition among the hospitals to establish their hospitals in the rural areas, which had never been the case in this country earlier. And there is a race. Many people in the private sector are coming forward and opening their hospitals in the rural areas where people can get the service delivered. So currently, the total number of hospitals in the country is more than 15,000. States and territories where service delivery has started are 28, and now it is crossed 30. Number of insurance companies are 15. So current status is from a small beginning in 2008. RSP is now one of the largest health insurance schemes, not only in this country but throughout the world. No other healthcare scheme, including the United States, Europe, or wherever in the world, nowhere in the world, a scheme has been implemented for healthcare as big as RSPY. RSPY is being recognized internationally. Many countries are visiting us and trying to share their architecture, our technology architecture, our best practices, and other things to learn how this scheme can be implemented. Everyone knows in US and other countries how the healthcare system is in mess, and they are struggling very hard to get the healthcare system stand and get the service delivered. So, the rollout process of the scheme is, first the enrollment is done, as I told you, digitized list of BPL is there are immense efforts for data screening, qualitative improvement of the data. So what happens, after the BPL list is available, there are camps organized all across the country, in the villages, to enroll the people with the reference list. So wherein their photographs are taken, their fingerprints decided that issuing the smart cards then and there will have a great impact. And people will come to know and see something has been done in the front. And they have become entitled to get the health services. They have the money in their pocket to go to any hospital and get the service delivered. So what happens? The smart cards are issued to the members along with the data in the chip, and they are also told which are the hospitals in parallel in nearby, where are the doctors, which are the doctors. And the beauty of the system is that as the number of cards are issued to the beneficiary, there is a back-end data flows from the place of the enrollment to the highest level for making the payment of a premium to the insurance companies. So as soon as the card is delivered to the individual, data is written somewhere in the system along with the chip number of the card, which cannot be failed. And once this data reaches to the server, central server, insurance companies are paid the premium for that. So that is how once the premium is paid, the person becomes entitled to get the health service delivered. Second is the transaction, cashless service delivery. Beneficiary approaches hospital for the choice. He can have a choice. He has, that is the beauty of empowerment of the citizen through technology. He has a choice which hospital he can go, and there is a competition among the hospitals who delivers the best service for the RSBI card holders. Therefore, the power comes with the beneficiary. Biometric authentication of a patient when he reaches to the hospital, so that no one unauthorized can get the service delivered. Doctor performs diagnosis and recommends predefined packages. So there is a concept of packages. There are 100 odd of packages, and every package has attached to some ailment, and after diagnosis, some packages are there. What are the diagnostics? What are the medicines? How much has been paid? So it's a predefined set of medical procedures and treatment plan, and it has some fee which is deducted from his premium. Currently, the premium is 30,000 rupees per annum to a family. Government is planning to increase it to 60,000, and many states have already gone ahead to tap it up with their own schemes, and maybe more than a lakh. So the technology architecture remains same. More and more beneficiary is given to the public, to the privileged, unprivileged class of people. So every package has a fixed cost and decided by the government. There is a committee within the Ministry of Labor, which is the implementing agency for this scheme, and Health Government, the Ministry of Family Welfare, Health and Family Welfare, and many prominent citizens and doctors. So they decide upon the cost of every package, and that once a person gets a treatment, that much cost is deducted from his available money in the card. So later, the patient, the beneficiary is given a cashless payment. Cashless. He doesn't have to pay a single lesson. Hospitals claim the money from the insurance companies later on. So claim settlement between hospital and insurance companies. Government is a group to MIS system. A very strong MIS system is required for the success of this. Because if the hospitals don't get a quick claim settlement, there will be no motivation for the hospital to provide a good service to the beneficiary. So there is a check kept over the insurance companies how much time it takes to settle the claim which has been raised by the hospital and parallel hospitals. Strict action on delay in claim settlement. False claim submission. If there is a false claim by any hospital, they are de-empaneled. And once a hospital is de-empaneled by one agency, he cannot be empaneled by any other agency. So no one dares to go for that kind of fraud. So, as I told you, the technology is secure, foolproof, authentic, cashless, and smooth for the patient. Maybe complex for the architects, technology providers, but simple and easy for the beneficiary to get the benefit. So, it provides a beneficiary empowerment, citizen empowerment. How it works? Smart card technology is used. In India, smart card technology is in use more than 10 years now. We took a lead in the year of 2001 with the project of driving licenses. Driving licenses is a most sought for application for So that time the problem was technology was in place, but unfortunately there was no standard for it, no interoperability for it. Few states went ahead, issued driving licenses on smart cards, but a smart card issued by one state was not chip was not readable in the other state. There was no interoperability, and there was a vendor lock-in situation getting created in various states. Government decided to come out with a technology standard. It came out with a standard of technology, which more than 25 companies now have adopted those standards and came out with their products, which are compliant to the standards, and there is no vendor lock-in is possible in the field. There is no non-interoperability, and as and when the contract is over from one technology provider or the vendor, second vendor, third vendor, fourth vendor, so multi-vendors are available to provide the same technology. But there is one very important, the control of the technology remains in the government hands. Control of the security remains in the government hands. The architecture remains in the hand of government hand. Industry is flourishing. It is not like, because no project in a size of this country can be implemented just by government alone. It has to be partnered with outsourced companies. With such a large geography and population, it is simply not possible for the government to deliver everything on its own. So, but the challenge is, government has to think of how much is the part of his own business, how much capacity government itself needs to have, so that the project can run very smoothly. So this is a very decent example. This project is a decent example. What should government come forward and take the responsibility of delivering that? Government should decide on a technology, should have a mechanism to make sure the technology which is being pushed at every corner of this country is compliant to certain standards, so that later on no one gets vendor lock or no one can have the non-interoperability. Those kind of mechanisms. So then NIC has a laboratory to test and certify the technology being used for smart card in India for all these multiple different national projects, for the driving license, RSVY, public distribution system, e-passport, all these smart card technology-based projects, they comply to national standards of a smart card, which is controlled by the government. So, the insurance companies, in case of RSVY, they partner with the technology providers. Technology providers source the smart cards in the market which comply to the standards, which are certified companies. They know the biometrics and data photographs, and they print the cards and issue it. We being National Informatics Center is a dream of organization of the government. Our role is to, as I told you in the beginning, we use different technological tools and sources, come out with those ideas. See, this country which we live in has always been great in generating ideas. The idea of aircraft, the Udan Yan, was generated in the epic era, which was stolen by some other countries, and some Wright brothers, and they developed and they invented the aircraft. We could not. So we have excellent people in generating ideas, but somehow we lack in getting the idea converted into a solution. So here, idea was great. Somehow we use different types of technologies to integrate and deliver it. That is the crux or success of this particular project. So defining the technology standards, ensuring the compliance, developing the crucial software components, it was done by National Informatics Center. So the crucial technology components include the key management system, which is the key to the security of any smart card system. So we provided the key management system for all these projects which I listed, so that the projects can actually all these components, technology components, key management system, chip encoding tools, chip data management, they provide a healthy ecosystem for any e-governance project which is a smart card technology based to flourish. In absence of all these components, So that these kind of securities are provided. There is a passive authentication which is based on the digital signatures, active authentication, symmetry key based access control definitions on the smart card so that no one unauthorized person can get to the access to the data which is residing on the chip. And then symmetry key based extended access control for hospital and patients. And at the same time, no Tom, Dick and Harry or general person should be able to get into the data of the smart card. But the authorized people who are sitting in the hospital, who are there to deliver the health services, should be able to get in and the access to the data. And that is what happens with the help of the key management system. Now coming to, I hope this 5 minutes left. I will just quickly share some slides to tell about the how what are the trends from the place where we started this scheme and what is the impact. Time? How much time? 2:30 is already. Okay, so the time was 2 minutes. Okay, thank you. So you can see the expenditures. There are a few slides I can share it later on. I hope these data will be available, presentation will be available in their whatever they publish after the conference. So you can see the family size. Every family size in this scheme is normally the government provides the 4 persons for getting the treatment per family. But so at the beginning the apprehension was that the family sizes are very large, so there are 10, 5. But when actual data analysis was done, it's not actually large. Most of the time it is either 4 or less than 4. Hospitalization ratio, number of people enrolled and number of people has been hospitalized. Average claim size, you can see the claims, 10,000 rupees, 5,000 rupees. This kind of treatment are given to the poor who never thought of getting the treatment, who always tried not to go to hospital, who always tried to sell his properties, his field, his agricultural land, his cattle, which is his livelihood, to get the treatment done in the hospitals. Now see, these are the impacts. They are getting all these treatment free just by showing the cards. Gender-wise, women has come forward in the scheme. There was an instance in the beginning, women were not coming forward, but now we can see in round 3, female hospitalization ratio is high, 64% more than. So impact is improvement in access to the healthcare. Hospitals being set up in remote areas by private sector, public sector hospitals also are competing with the private sector. That is the beauty. They say that they don't have money, but then they get the money through RSPY channel, and they do a new, health providing services within them and bringing. They have a separate counter for RSPY beneficiaries. So now this RSPY card is becoming a vehicle for various other government service delivery. You can see NREGA, you can see building construction workers, railway porters, postmen, domestic workers, street vendors, BD workers, taxi drivers. All these are getting added into the basic user base. So I think I have many other slides, but time is running out. So I just leave it at this point, and if there is any time for questions, fine. Thank you.